All right. So let's start. So I'm very happy to have Susanne Gaube here today from UCL. She's from the Global Business School for Health over at UCLIC. I think a few of you already know her. Susanne first studied in Germany, in Regensburg, then did her master actually here at UCL, then went back to Regensburg, and then finally decided to come back to London. And I think you've been here for 1.5 years approximately now. And yeah, without further ado, I think you're also going to introduce yourself a bit more. So very happy to have you here today.
Brilliant. Thank you, Mark. Thank you for having me here. So I have very familiar faces around the room, but I'm also very excited to meet everybody else. So today I brought a really mixed bag of studies all around understanding AI implementation and human AI interaction. That's my main field within healthcare. But as you will see in a second, I'm very much not married to a specific methodology, but really use a very mixed bag of type of methodologies to approach this topic. And so yeah, so I'm a lecturer in human factors at the Global Business School of Health. We are a very, very feared institution within UCL, very new. The first cohorts of our students started in 2022. And we study health from really a very multidisciplinary perspective. We have everything from health economists to clinicians to informatics to biomedicine, like literally every discipline that you could think about that is related to health, they are within the Global Business School. So it's really fascinating to work in an interdisciplinary environment that you are also all very aware of. Yeah, so my background is originally in psychology. Health behavior change was mostly my PhD topic. I stumbled more or less into human-computer interaction. And now I'm married to human AI interaction for a couple of years. And so my research agenda is also a bit of a mixed bag, representing where I'm coming from. On the one hand, understanding the influence of AI-generated advice on clinical decision-making, but also understanding implementation requirements for these kind of technologies, so we can really implement them according to the needs of the end users. Then I've done a couple of studies on patient acceptance of AI-enabled health products, and from my roots, but more on behavior change, I'm really interested in how we can use technology to support patients with multi-drug resistant organisms and understanding their environment and understanding how we could, within the realm of antimicrobial resistance, use the patient examinations. But I'm leaving that out with tool. So why AI in healthcare? As many of you might be aware, there is a great potential of using AI and machine learning in healthcare, on the one hand to improve clinical decision-making, but also really optimizing workflows, reducing repetitive tasks, and expanding the knowledge or supporting clinicians with limited task-specific knowledge to support them in their decision-making. And we've seen on the one hand, these like two eras of AI in medicine, the very unimodel kind of era, where we have one specific data set, such as PET-CTs, X-rays, and so on, and very limited models that can do exactly one task, diagnose this CT image, for instance, detecting pneumonia, whatever it is on there. And now we're going into the foundation model era, where we can integrate multiple sources of health data, such as clinical records, such as medical images, such as lab tests, but also audio, video imaging, to in the end not only do one task, such as diagnosing, but actually many, many tasks, such as treatment, recommendation, predictions, and writing clinical notes. Yeah, so we have seen some of these unimodel kind of prediction models achieve at or even above clinician level performance for about 10 years now in very, very different medical tasks. I'm working a lot with image-based tasks, so brought a couple of examples. So that is very established at the moment already. And we've seen the first bigger clinical trials now that at least show that if you implement AI-enabled decision support systems as a double reader system, it can massively reduce screening time within radiology. So that's the biggest clinical trial at the moment out of Sweden. And it shows that we have workload reduction. However, at the moment, the cancer detection rate is not significantly different if you use these decision support systems within mammography screening or if you don't. So there's still not a lot of evidence for clinical improvements in the end. And now we're stepping into the foundation model world, where already some of the models show that they cannot, based on like one source of imaging, such as retina scans, they can detect ocular diseases, but then also predict some more systematic diseases, such as stroke, heart failure, Parkinson's disease. So now we're going to be a bit more disease agnostic. So that's going to be really exciting as the next step within AI in healthcare and medicine, but also raises a lot of concerns. Like, what do we do with this kind of information? What if I have, what does it mean for consent if I have these additional findings on medical scans that have been taken for one purpose and now could have the potential to diagnose something completely different? Is this new? Is this something that we always had? These additional findings based on medical scans. So what does it mean? At least I think for consent, that's going to be very interesting. But yeah, where are we right now? So the technology is really advanced. We're seeing new papers every day. I think everybody that works in that field knows that you can never even try to like be on top of the literature because it's so fast and so quickly. However, in reality, in clinical practice, we still see that the systems are not widely implemented. Besides radiology and some other image-based fields, it's actually very rare that you see models properly implemented in healthcare facilities, especially then also outside of university hospitals and proper like GP care. And again, as I showed you, while we have some evidence that we see workload reduction, there's very limited evidence that we see proper clinical improvements when we adopt this kind of technology and implement it. And so I'm really interested in answering these kind of questions, like why do we see that and how can we optimize that? So one of the studies that we have done, we interviewed a bunch of model developers, both commercial and academic model developers, and IT specialists within hospitals that are responsible for the implementation of these technologies, because we're thinking they are really the ones that are at the heart of implementation. And so we first asked them about what's the current state. The paper was published in 2023, so it's a bit old for that kind of research, but still knowing the literature, not a lot has changed in the end. And so what they were telling us, obviously there are many, many different models out there for various use cases, but besides radiology, dermatology, pathology, there are very few products on the market that people could actually purchase. Then we see strong regional differences that the US and China are clearly leading this research, leading the market, while Europe definitely lags behind to a degree, and that data protection and regulation is really one of the reasons why Europe is lagging behind. Back then, they were telling us, that these systems are mostly used for very specific use cases to, for instance, be a double reader in repetitive tasks, and they can save time. And However, that this task specificity was also really seen as a limitation. There was still this liabilities and big unsolved problem, like what happens if a medical decision was based on one of these predictions and in the end it's an incorrect prediction, so it was liable for that, and the lack of proper explainability of this. And so then we wanted to focus on these few products on the market, because I did most of my research in radiology, and it was, what do you mean? There seems to be many, many products. And so one of the postdocs that was working with me in my former job was really interested in precision psychiatry. And the idea of these decision support systems in precision psychiatry is to optimize the conventional psychiatry or psychology approach, where you as a patient would see a therapist, you have conversations with them, the therapist makes notes, maybe you have a questionnaire, a diagnostic questionnaire, and basically on this very limited kind of evidence, the therapist would decide a diagnosis and a treatment. And it's very subjective, it's also very much based on the psychological school that the therapist is coming from. And so often we see that treatment within psychology, psychiatry is not working particularly well. And we need to try a lot of different medications and so on until we see improvements. And here, the AI-enabled approach would be you have a lot of patients for whom you have multiple different types of data, such as image-based data, mobile data, electronic health records, lab data, demographics, and so on. And you can basically cluster these patients into different groups that are very similar. And then we could see that based on their similarity, some treatment approaches would work better for some patients than others. Even if two patients get major depression as their diagnosis, based on the endophenotype, we could say this kind of medication has a higher chance of working for patient A within group A than patient B. That's the idea, to just have a much more enhanced and objective this knowledge base to make the clinical decision and the treatment decision. And so we were then interested in, okay, what kind of technology is that's going to be? And so we started with a patent analysis to see what's going to come probably in the future for us within that environment. And we looked for patents for mental health applications to diagnose, treat, predict as a decision support system. So not patient-centered, but clinician-centered, really supporting them. And so what we found in the end were 279 patents that within our decision support system or within our inclusion criteria, we found that the majority, almost 2/3, were diagnostic tools to improve diagnostic decision-making in mental health. About 100 of them were treatment predictions, so really identifying the best kind of medication or the best kind of treatment for the patients, and a couple of them were prognostics, so comparing the prognostic, if a patient, prognostic prediction for a patient that would get the treatment versus wouldn't get the treatment. And most of them were for multiple different diagnoses, so diagnostic, agnostic, and only a couple of them were for specific conditions in there. Depression and autism were the most widely seen conditions. And when we looked a bit more into detail, what are the data sources? So we have a lot of systems that use behavioral data, so basically mobile data, any kind of sensor data that we could see. A couple of them use biological data, the neuroimaging data, experience data, so in the end, questionnaires, clinical records, and socio-demographic information. You see, so it gets really a wide range of data that's included in these kind of patents. And as we've seen in our interview studies, clearly the China and the US are leading this trend, the patent application process, like very strongly. And then we looked into CPC codes. So to make that very easy to understand, it's basically different technology aspects and a combination of technology aspects. And we started with 2015 and ended in 2022. And basically what you see, the complexity of the patents really exploded. So the combination of different kinds of technologies and features, underlying features, really exploded in these couple of years. So we do see a strong advance in this kind of technology. And so we found it really, really interesting just to see this kind of what's going to be there. And just as one example, the most highly cited patent from 2019 was an application for risk, I think it was treatment application for addiction. And it was basically based on your location data that you pre-selected as a patient with a history of addiction. And if you add an area that is highly risky for you for your addiction, for instance, if you're a drug user and you go to the place where you usually buy your drugs or near that place, the system would automatically send alert to your therapist. So the therapist could reach out to you to intervene. So that's the kind of technology that you could see within these patents. And after looking at the patents, we were like, okay, and what's here right now? What can we see right now if I wanted to purchase one of these products? We were again interested in like mental health, AI products, decision support systems that have some kind of certification that are regulated to any kind of degree, because they all theoretically should be regulated as a medical device, so software as a medical device. And in the end, we found exactly 7. And this was a really, really intense search. It almost drove us crazy. So we used the patent data to try to identify vendors. We went into all major conferences, psychological and psychiatry conferences, who is marketing, who is at their exhibition lists, and so on. It was really a nightmare. Don't do that ever. It's really nightmarish. And yeah, we only found 7, which is really, really crazy, I think. And here you can see the market entrance. When the scientific evidence was published, that's the blue dots, and then they got clearance, certification and clearance. I think the most shocking part to us was 2 out of the 7 products published any clinical evidence. The rest of them don't have any openly available evidence, and we reached out to all of them. They didn't send us anything, which is also like, I'm not particularly familiar still with the patenting process. You are much more familiar with that from our conversation before. But we all thought, like, of course, like, if I'm a clinician, I want to purchase this product, I want to see their validation study, I want to see that this is actually safe, and I want to see that there is actually, like, improvement in outcomes. And yeah, 2 published something, which is, again, shocking. And it really shows how early stage this technology is in the end. And just to see these products, a lot of them have CE certification, which is slightly easier for these kind of technologies to get FDA. Only 2 have FDA clearance. And 3 out of them are for diagnosing autism in childhood, in very early childhood, and they usually use some kind of video data to make this early diagnosis. I think one has also eye tracking, only video based. Then we have a couple of them to diagnose multiple kind of disorders based on chatbots. That's the ADA products, I think. And then depression medication prescription based on microbiological and genetic data. So that's really trying to identify the best type of antidepressant for a patient in the end. That's the kind of technology that is actually out there, at least until we looked into the market. But so it really shows their claim that there's very few products on the market was very valid. Fair enough. Okay, going further in implementation criteria and implementation requirements, based on our interview study, their performance was by far the most important topic that everybody was talking about. Like, clearly, these systems need to perform very, very well, and they need to be revalidated constantly after deployment, because we see that the performance deteriorates after implementation in the clinical setting. And I talked to a lot of clinics where they implemented a model, and a couple of months after implementation, the performance dropped so low that they had to, in the end, take the model out of their decision-making process because they couldn't get it back to high enough performance. And so this revalidation process is really problematic for clinics that have very limited IT support or in-house development support. So that's really something that is crucial for implementation, that you have support either from the vendor or you have enough in-house resources. Then costs was a topic, like a bit of disagreement. Some saw it more as a marketing investment, while others saw it as like, yeah, it's a decision-making criteria for us. Then system integration was a big topic that they were discussing. On the one hand, can these systems work with our existing infrastructure, and how easy are they to be integrated? How easy are they integrated in our workflows? Are they customizable in the end? Then user acceptance and trust was a really big topic here, and explainability. That was a topic that came over and over again. And in the end, training needs. How far do we need to train our healthcare practitioners in using the systems and understanding the limitations of the systems? And we again saw pretty strong like difference between we need to basically computer science our clinicians, especially the radiologists, versus yeah, they just need to basically understand the limitations of the system. We wouldn't also tell them or exactly explain them how each technology within healthcare works. Maybe don't need to give them a computer science degree. And here I wanted to discuss a bit further into the user acceptance and trust. We did a couple of studies again within mental health because we were then really interested in future clinicians' trust in these kind of decision support systems and what would be aspects that are really important for them. So we did a survey study where we introduced them 2 types of tools. The one was a very low-risk feedback tool that we found on the market before. It's basically a record. You as a therapist and your patient, it records your therapy session and gives you as a therapist feedback on your therapy session based on a specific therapy model, and basically it gives you advice on how to be more empathetic. So it's very low risk because it's only giving you feedback. And then we had a higher risk application, which was a treatment recommendation. Again, it's based on audio recordings from patients. It would generate a risk score for the patient, especially a suicide risk score for the patient, if you need to intervene with the patients. So a much higher risk application at the end. That's what we showed them. We showed them how they operate, how they would work. And then in the end, ask them about their intention to use and rate perceived usefulness, perceived ease of use, social influence factors, AI anxiety, but also the tool understanding and cognitive readiness for AI is a bit of the basic understanding. And we saw that very different factors are in the end relevant for use intention for these different tools. And that makes sense because they are very different applications. So AI anxiety was relevant for both. We thought it was actually only a control factor, but in the end, it was one of our strongest predictors. Perceived usefulness was a significant predictor for both tools. But interestingly, ease of use was actually a non-predictor for the feedback tool and a negative predictor for the risk scoring tool, for the treatment recommendation tool. So actually, the easier it is, the less likely are you to use it. So apparently, it's really like, it's too simple to use. I really don't want to use it for something that high stakes. And we like tested this path model multiple times. If there's some problem with our data, but it wasn't. So because we were like, that's so weird. But yeah, so it really shows that we cannot just think that all of these variables are similarly important for different products for very different applications. And in the end, we did a meta-analysis on using the classic UTAUT variables, but also a lot of individual difference variables, such as attitudes toward AI, trust in the system, risk, anxiety, AI anxiety, personal involvedness, and so on, to see if use intention was predicted. In the end, we found significant evidence for all of them, so that we did a meta-analysis on that. The UTAUT moderators didn't were not significant. But so in the end, it really, we did find this original Utah model verified, but also saw that clearly that's not the end of it. There's significantly other variables that are, that's not only technological characteristics. And then when we were talking about implementation challenges, because we were seeing that not a lot of hospitals have anything implemented, we did see that stakeholder involvedness is a really important aspect. And here it's not, if it's a top-down decision that the head of department decides we need these systems without bringing the rest of the the rest of the team on board, that's really problematic. But it's not only the team in the end, it's also financial department, regulatory, and so on, and patients that you also need to bring them on board. But then regulation is really challenging for these systems. You've seen not a lot of technologies are regulated. The regulation process takes ages. The technology moves super fast. The FDA still hasn't, I think it hasn't today regulated a single of these foundational models. The FDA is very much still in the unimodel era stuck. So it's really problematic for clinics to make a decision here, even if they have to, if they build something themselves, how to regulate that, if it has to be regulated, if you use it as a research tool, and so on. Then a lot of technical challenges. On the one hand, the classic problems with AI, limited data, limited high-quality data, especially also data on rare diseases, which leads to biases in the training data, the poor infrastructure within healthcare, so implementation is always really, really challenging if your existing infrastructure is already decaying, and that most of these systems clearly do not have user-centered design, but are very, very tech-driven, not a lot of user testing in the end. And also, yeah, lack of IT professionals within healthcare environments to maintain these systems was seen as one of the biggest challenges, actually. And let's briefly talk about patients. We did another study on actually not a decision support system, but a patient-centered tool, where we were really interested in user acceptance for these kind of self-screening tools that are now on the market. So they work very well in ideal conditions. They work so-so in real environment conditions, but they still work better than in comparison to a GP doing the screening or yourself doing the self-screening. But the user acceptance and uptake is really low. Even in countries where you can download them free, such as in the Netherlands, you can access a couple of these tools for free. 1% of the population uses them, which is.
Do we know why?
So there are a couple of studies, so most of them find it too tedious to actually do it. There's a bit of risk perception, scaredness, but I think it's mostly like it's very tedious for people to just do the recording and they don't trust the system well enough. And what we were trying to understand is a bit why, to a degree. And we used a conjoined experiment where basically you create different vignettes where you vary some attributes of two providers. So we explained to our participants that they can either go and see a dermatologist in their practice and have the checkup, or they can use one of these systems. And that's basically the different attributes. So the cost varies, the expertise of the system varies. So we are telling them it's either an early resident, a dermatology resident, or an expert, or it's a system that is well validated, has certification and so on, or it's an experimental system, more or less, and privacy or any data shared with third parties. And then we also changed the result details because we know explainability is the big topic within AI, but also that a lot of patients are really frustrated if they only get a diagnosis without any explanations. So we thought that's also relevant for both like human and AI interaction in the end. And so we gave them different vignettes and asked them which provider do you want to choose. That was the decision that they need to make. Then they should evaluate both the chosen provider and the non-chosen provider on trust in the provider acceptance, accuracy, perceived accuracy of the screening, and overall quality of the provider. And we had a couple of additional survey questions where we were interested in demographics, medical mistrust, attitudes towards AI, AI anxiety, health anxiety, and data protection concerns. And so what we found this very strong preference for the human provider, like very strong. So we also saw this very strong lack of interest in the AI system, in the screening systems. We did see that our participants preferred the free or cheaper version, the free version, or the cheaper version, that was the most expensive version. They did prefer a system with higher expertise, or a provider with higher expertise. Data protection was already not significant, was already not important. We should say the data was collected in the US. Maybe that would have been different in Germany, where data protection is clearly always one of the highest important scales. And this result detail, so explainability and the level of information that you get, was not significant. So that was really interesting. We did a lot of other analysis, but that's the main outcomes. But interestingly, when we look at this evaluation of the provider, even if you did not select the AI, or even if you selected the AI, all participants always rated the human higher. So that's participants that selected the AI, and they do rate the human to be of higher, they trust the human more, they found it of higher accuracy, the screening results, and they also find the overall quality better, which is interesting, even if they selected them. So very strong algorithmic aversion effects. One interesting study result out of that study was that individuals higher in medical mistrust, so that do not trust healthcare professionals or the healthcare system very well, they were actually much more interested in using the apps. And so our conclusion was that individuals that are least likely to actually seek screening, professional healthcare screening, are the ones that might actually be the most interested in using them. So that might actually close a gap. However, on the flip side is individuals high in medical mistrust are usually also marginalized communities for whom these systems are not built, because the training data is clearly built on non-marginalized groups. We have, again, data bias. But yeah, it was at least one interesting finding where we were really saying, okay, that should be also maybe for the development of this system, so for the marketing and for a public health approach, that would be a really good avenue to go. And then finally, for the interviews, we asked them for threats and opportunities of this system. On the one hand, in the threats, they really saw automation bias as a big issue, over-reliance on incorrect advice, cyber attacks, and I think the biggest topic at the moment is loss of skills. If we train clinicians only with the use of these systems, can they do it without? Can they read a trajectory without AI support? And is this really a problem? That's in the next question. Is it a problem if they can't? We wouldn't also expect some clinicians to do some stats, and we still train them on the stats. But is it problematic if they can't do them by hand? And then, yeah, opportunities, especially the reduction in workload, that is seen as the highest opportunity of these systems, actually not accuracy or improved diagnostic accuracy. And yeah, enabling personalized and truly personalized care is seen as the biggest opportunity. However, if you're thinking about this human AI collaboration, we would think that theoretically, in ideal conditions, a human AI team should outperform a standalone human performance, but also a standalone AI performance. However, in most cases, this is not actually the fact. So that's an example, a diagnostic example again. That's standalone AI model performance in the diagnostic task. That's two different versions of AI-assisted human performance, and that's non-assisted human performance. So the non-assisted humans and the human AI teams both lag behind the standalone AI model accuracy. And that's one example, but there are many others. There's a very new meta-analysis on that also that shows overall we don't see this added benefit of human AI collaboration in most tasks, whether it's clinical tasks or non-clinical tasks, but especially clinical tasks. There's very, very little evidence for collaboration improvement. And so we were also really interested in that. And so we did mixed methods in a HCT study where we had 50 experts, radiologists in the end, and 75 non-experts, which were students and interns, review 50 HCTs 3 times in 3 different conditions. And make a diagnosis for each of the HCTs and rate the usefulness of the AI-generated advice and their confidence in their decision and the reading time. And they either did not receive any AI assistance, they received a very basic AI assistance, basically only telling them, I do see a bleeding or I don't see a bleeding on these cases, or a basic explainability version where around the bleeding you see bounding box, based annotation in the end. And we did a think aloud study with the novices and an eye tracking study with the experts. We also theoretically have the data from the novices, but we're still processing it. It was such a disaster, the eye tracking with the computer vision, because we used HCTs that are very dynamic. So doing the eye tracking with these dynamic HCTs, the analysis was again very disastrous. So that's without any advice, you just have your basic interface, a basic diagram view that radiologists would use, bit of patient information. Then here you have the basic advice condition where you only see, there is a bleeding somewhere on the scans, and then the explainable one gives you also a bounding box around the bleeding. And so usually original data is not supposed to be edited, so we gave them 2, an unedited version, the edited version. And so what did we find? So the experts only benefited from explainable advice, while the novices benefited both from basic and explainable advice. And to me, still not shocking. To the radiologist, it will always be shocking that performance drops if you give incorrect advice. Then, more interesting, explainability in the end only mattered for true positive cases. So only if there's actually a bleeding, then explainability matters and gives a significant improvement about both in experts and novices. And at least we did see both in experts and novices that false positives, so where there's a bleeding around an area that's actually not a bleeding, didn't significantly decrease performance. So this over-reliance there was a bit, at least we didn't find a lot of that explainability would increase over-reliance. And interesting, our novices achieved above expert level performance if you gave them explainable AI advice in true positive cases. And actually, I think that's the only group that actually outperformed the AI model's prediction. So, again, the experts were not thrilled about these results. And what we also found is that while the entire literature talks about, in the end, over-reliance and incorrect advice, we saw that under-reliance is a much bigger problem for overall performance, because the system is clearly better than 50%, so you have a much higher system, like that the system is correct is a much likelier version, and so under-reliance is really a bigger problem. And explainability can reduce over-reliance, under-reliance, so especially in the novices, it halves the under-reliance. So definitely explainability helps quite drastically here, but it didn't increase over-reliance, so that's good. And from the think alouds, so among the novices, we found that this under-reliance comes mostly from uncertainty. So it's less that I completely try to ignore the AI or I'm actively rejecting the AI. It's more, I'm just not sure. In the end, I decide in one or the other way. And again, here you can see that the explainability almost took a third of that uncertainty away, and that explained the reduction in false cases in the end. So that it's really this, I'm just unsure. For negative cases, so it's actually bleeding cases, what we found is the classic, like more interface design problem. Here we found a lot of misclicks actually leading to under-reliance. And that is, so we asked them, do you detect a bleeding, yes or no? And they didn't detect a bleeding, and the system said there isn't a bleeding, and they agreed that this is because the system there isn't a bleeding, but then they just clicked the first button. And we didn't have a pre-selection, it was just choice hierarchy. In the end, we only saw dismissed clicks in the negative cases, in the non-bleeding cases. And that again shows really like we should not have a very easy choice architecture, or we should really think about a choice architecture in these support systems. And then in the eye tracking studies with the experts, we saw that overall, that's the overall focus on the head CTs. We saw that they focused significantly more on the CTs in these under-reliance cases. So you could almost predict if they under-rely, how much they engaged with these cases. So again, that indicates a high level of uncertainty because they were screening them so much. And if you can see, that's the basic advice condition. They just basically missed the bleeding a lot. For small bleedings, and they just missed them a lot. But in the explainability condition, they did see them a lot more. So at least they were aware of them and then they decided against. So they decided, I think it's an artifact and I don't think it's actually a bleeding, but at least it's an active decision. So they were much more aware of the bleedings, which is again, definitely making the case for explainability. And so in conclusion, like I walked you very quickly through a bunch of different researches all on this, like trying to explain how we get there into this ideal promise scenario. In the end, on the one hand, we need better and compelling evidence what works in human AI collaboration and implementation, and that the systems really do lead to better outcomes. We need much better regulation and transparent regulation, and we need more products on the market that are regulated. Then we need to help the clinicians to overcome their trust issues with the systems, to also reduce the under-reliance problem most likely. For that, we need significantly more implementation, human factors, so human-computer interaction research on this. And we need much more international collaborations on data sharing, on model sharing, on sharing best practices in the implementation. And yeah, for the clinicians, always really important, the reimbursement strategy. But I think that's really a lot more research is needed to support the implementation of these systems. And yeah, that's so far for me. Thank you so much for your interest in my work and for your attention, and I'm happy to answer questions.
So, are there already any questions also online?
Thanks a lot. Those lots of really interesting applications of AI, very wide ranging. So, going back to the idea of precision psychiatry, so there's an assumption, that assumption of precision that you're saying that what mental disorders really are is fixed natural primes, and that they correspond to clusters that the machine learning model comes up with. But you still in that study use the terms from the DSM, and those terms have kind of evolved in our culture over the last 150 years. We've developed certain understandings of those terms. There's something meaningful that it means to someone to have depression. Watch all the TikToks about having depression. But there's something interesting about, presumably, if this is precision psychiatry, then the idea is that actually the label will eventually be replaced with what the cluster really is, and kind of that's a very different type of acceptance. It's something we lack knowledge for, and I wonder if we even could know what it would be like to kind of pass things through the labels that the model has developed. Okay, now here's this new thing that, like, new way of being almost.
I completely agree. I think that's one of the most interesting applications and probably the one that will give the most resistance. And reshuffling the DSM or the ICD-10, and like actually what we are now thinking is that autism, that's depression, might be completely different underlying mechanisms, and therefore that's why some of our depression medications don't work for some patients, because the underlying mechanisms are not the same. I think if the system can show through this treatment prediction approaches that actually feel much better at getting patients the right treatment early on, I think that could reduce the reluctance in changing the labels significantly. If we actually show, if you follow this treatment prediction, independent on what your diagnosis in the end is, I think that could really help, expand that quickly. That's a bit on the idea of expanding knowledge, that we could really completely redefine labels. And maybe that's, I think that's one of the most exciting parts down there. But at the moment, at least in the patents and the products, they are working very much with the original labels. Absolutely. Which misses the point to a degree, I would say. But yeah, it is what we found.
Thanks again for the talk, it's really great. I was wondering, you spoke a bit about the training data being drawn from people who have quite ground access to healthcare already. I wonder if you could speak a bit to how like training data from the marginalized students that you mentioned, what that might be for that.
Yeah, happy to speak on that. So a lot of what I say in the end comes from the domains I work mostly in. So within radiology, a significant amount of models in publications, but also that are used in commercial products, are based on 2 or 3 data sets that are from North America, that are from Stanford or Boston and Harvard. So that's clearly not a representative set of patients that are having access to these high-end facilities. And that's a big problem. That's why a lot of these, even commercially available works, are significantly biased. We also know, especially with skin cancer detection, again, data sets are very, very biased. There's a lot of research now at the moment happening, a couple of researchers in our institution, for instance, that try to work with smaller, get models up and running with really small data sets that can specifically be trained within institutions, that it can be really tailored towards the population within your institution. And if you're in an institution with much more diverse patient set, that they should work significantly better. I'm really excited. I'm not on the computer science side of that, but I think like the studies that you see are really exciting, that much smaller data sets are much more feasible for that. And there's a lot of international collaboration, especially on rare cancers. So there's an entire collaboration in South America that shares their data sets on rare cancers. There's a European consortium that shares data on rare cancers to again train these models for these rare diseases. And I think here we go into the international collaboration. We cannot do that within small data bubbles, but I think we do need this collaboration. We need these selected few cases to be put together in. I don't know if that helps at all.
Okay.
Thanks very much. That was really. I just wanted to go back to the point you made about performance drops after implementation. It's in some institutions that you sort of introduce these AI models and they seem to work really well, and then suddenly after 2-3 months they're not working at all. I just wondered if you could shed more light on why that happens.
So I think there are a lot of hypotheses on it in the end. Again, I'm not a computer scientist, so I speak mostly now from anecdotes that I hear. And that it again comes down to what has the system, what training data was used for training the system, validating the system, and what's the actual data that's within the healthcare system or in the institution, which constantly changes even. You might have very different types of patients coming in one once versus another once. Weirdly, these data shifts lead to these strong shifts in model prediction. But sometimes it might be something as we change the scanner and the model just cannot deal with that scanner and it needs to be completely retrained, but sometimes they don't get it up and running again. And for some institutions, it's really like, I work with an institution in Chile that developed a model for X-rays for hand fractures, and it was home developed. It worked at 97% accuracy, and it dropped, and they don't know what happened. And they're now in the process of really trying to understand what's happening, why it's not working now. Their accuracy is about 70-something%. Like, you cannot use that in clinical practice anymore. And they just don't know why. And I think that's really, again, the black box problem of the systems, that sometimes you just don't understand that they're not at the same level. And that's really, even if it's a home developed system where you have the IT resources to build them, and then you cannot maintain them, it's really good with the systems. During COVID, a lot of these systems, especially for sepsis detection, really started to freak out because COVID patients look similar to patients with sepsis. It's really the data in the end that goes in, and the patient population that goes in. And if there's a shift there,
1,000.
Okay.
Thanks, that's great. And so I guess the follow on from the conversation that's just been happening is that the model needs to keep learning as opposed to it being a one-time training and then a subsequent implementation with new data. Have any of the systems that you've looked at implemented that notion of continuous learning and training, updating the training based on new data that is more current and uses a different scanner and has a different patient population?
so most of them do, like especially the commercialized products that are ongoingly maintained, absolutely. It's a bit of a problem again with regulation, because of course, if you regulated a product in its current version and then it's actually learning and dynamic, so that makes also regulation really, really challenging. But yeah, most of these systems are supposed, it's the point of them, that they can learn and that they can adapt. And yeah, especially for the research applications, that's definitely the case. To a degree, the commercially available systems are a bit unclear what's happening because they're proprietary, but I think like, yeah, that's the goal. But that's also the main challenge in certification.
Okay, quick question.
Why people been saying that the skin one, and I wonder if there was the funding highlighted the fact that people may be afraid to have a diagnosis and without having the doctor there to talk to.
Yeah, I think that's an absolute valid, but I think usually these so what these systems do, at least the skin cancer apps that were on the market when we did the research, were not giving you a diagnosis. They were only like, you should go now to a clinician to get a second reading. They would not actually give a diagnosis because they were not certified to do that. So that is, I think, usually in the patient-centered technology, most of the time they would not diagnose you.
They already use it in my center. You upload the picture, the doctor asks you to upload the picture, and then you receive your diagnosis, and then you will have an appointment within 2 months to discuss the diagnosis.
Oh, that is scary.
And so that's why I was
I mean,
surprised
yeah,
that
we
there
didn't.
was-
Yeah.
Understanding.
Yeah. Yeah. No, health anxiety was also not a significant predictor, weirdly enough. We also thought it would be.
Yeah, because you wait for 2 months and you
Yeah.
have a diagnosis that doesn't look good.
No,
It
absolutely.
doesn't do anything.
But the system that we looked in, we explicitly told them it will not give you a diagnosis. It will refer you
That
to an
would be the
expert. If
difference.
there seems to be something of concern, it will refer you to an expert. But again, in the end, it's the same, right? If you will be yeah, absolutely, absolutely. I also thought that health anxiety might be a very strong predictor, but weirdly enough, it wasn't. Yeah. And there, last question for you.
Like the for AI, because I noticed from your experiment, it seems that people have like longer path than the talkers about the AI diagnosis and certification. I was wondering, is this like a mainstream, like, accepted from patients for AI application? Not from your conjoint experiment. Yeah, even though they should AI, the AI is perceived like less reliable than.
So there are lots of different underlying mechanisms that could happen. It could be really either a version, it be truly they say that I mean the rates that they should perceive it as lower quality as a human clinician, which also I think that I don't know how it would be the same for me. I would trust the dermatologist slightly more than a self-taken picture of me and because I think there's a lot of bias in the data there. I think maybe it's also the process they have. So it could be that. It could be the study was published 2024. The data was collected 2023. It could be already changed. Like now we all interacted with ChatGPT constantly. Maybe that has completely changed now. It was pre-ChatGPT era data. So maybe we all now would trust the system very much with that because we interact with AI products. So I think that would be really interesting to replicate exactly that study now to see if anything changed. I think, yeah, the problem that the computer scientists have and that the technology is moving so fast, the same problem is with us. Like anything that is I say about trust in AI might change within a year or two, the more people interact with systems. But I do think that there was a general like algorithmic aversion effect that we saw because but in all metrics they underlying it, even though they chose it. So I think there was curiosity in these participants, but clearly they that expert. But what the underlying mechanisms, we didn't in the end. We should have done interview follow-up studies with them. We didn't to understand why they still distrusted the system more, even though they chose it.
All right, let's thank Susanne one more time.